So welcome to Chapter 54. This is going to be care of patients with pituitary and adrenal gland problems. So don't get me wrong, I understand the endocrine system can be confusing, so we're going to go through it kind of slow. And if you have any questions, you can message me or whoever your instructor is. You can go look at your online resources, but just do what you can to try to understand the content here. So the priority concepts for this chapter are fluid and electrolyte balance, cellular regulation, and immunity. Pituitary and adrenal glands secrete hormones that control cellular regulation, which is how cells function, divide, grow, and respond, which in turn affects fluid and electrolyte balance. Starting off with hypopituitarism. Yeah, that's a mouthful. So this is the deficiency of one or more pituitary hormones, most commonly due to a pituitary tumor. Deficiency of ACTH, which is the adrenocorticotropic hormone, and TSH, which is your thyroid stimulating hormone. These are going to be the most life-threatening because they decrease secretion of vital hormones from the thyroid and adrenal glands. This is most commonly caused by pituitary tumors, and tumors can compress and destroy pituitary tissues. Other causes include malnutrition or rapid fat loss, shock or severe hypotension that reduces blood flow to the pituitary, which will lead to hypoxia, infarction, which is tissue death, and reduced hormone secretion. Other causes include head trauma, infection, radiation and surgery, AIDS, or it could be an idiopathic, which means unknown origin. Remember, that head trauma is going to be one of the reasons that we can have pituitary problems because your pituitary gland is in your skull. The signs and symptoms for hypopituitarism are going to depend on what hormone is affected. You can find these hormones and their effects in box 54.1, and it's going to give you the details of each hormone that's affected. Neurological symptoms of pituitary tumors are usually first noticed due to vision changes, especially changes in your peripheral vision. Headaches, double vision, and limited eye movement are common. So think about what hormones your pituitary gland is going to secrete. Laboratory assessment of hormones like T3 and T4, even though it doesn't make T3 and T4, it makes that TSH that's going to affect your thyroid. You're also going to check testosterone, estradiol, and prolactin. Those can be measured easily. Low levels are going to warrant further pituitary assessment since the pituitary hormones stimulate other endocrine glands to produce or secrete their respective hormones. For imaging, pituitary tumors can cause changes in the bony nest where that pituitary sits in your brain. So changes can show enlargement, erosion, and calcifications of that area. For treatment, patients with hypopituitarism are often going to require lifelong hormone replacement therapy. So we looked at hypopituitarism, and remember hypo is low. And now we're going to look at the opposite side of that coin, and it's going to be hyperpituitarism. This is going to be when we have an over-secretion or production of hormones in your pituitary gland. A lot of times this can be caused by an adenoma, and adenomas are classified by the hormone secreted, and as they get larger, they can compress the brain tissues, which will cause both endocrine and neurologic problems. Hypothalamic issues can also cause excessive production and releasing of hormones, which can overstimulate a normal pituitary gland. For your assessment, it's really going to depend on which hormone is in excess, and you guys can look at box 54.2 to see the list of hormones and the effect they're going to have if they're in excess. And we can also do suppression testing. So one of the things we look at is that oral glucose can help suppress the release of the growth hormone. So we will look at blood glucose levels if we are concerned about an overgrowth of the growth hormone. So your growth hormone is one of the hormones that your pituitary gland secretes. This is a really good example of oversecretion of your growth hormone. This is called acromegaly. So acromegaly has a gradual onset with slow progression. An early identification to this disorder is key to prevent irreversible enlargement of the feet, hands, and face. And in this picture, you can see this young lady. Usually this growth hormone oversecretion occurs after puberty. So you can see she looks rather young in the picture on the left, and then you can start to see where she's starting to have more prominent facial features on the right. Changes include increased skeletal thickness, hypertrophy of the skin, enlargement of organs like the liver and heart, the breakdown of joint cartilage, hypertrophy of ligaments, and vocal and eustachian tubes. For your patient education, please let them know that skeletal changes are permanent. So if their hands and feet grow due to this, if their nose grows due to this, anything, it's not reversible. That's why it's important to catch it early on. For hyperpituitarism, the goal is going to be to return hormone levels to normal and to reduce headache, visual disturbances, and reverse any bodily changes if possible. For non-surgical management, drug therapy can be used alone or in combination with surgery and radiation. Common drugs include bromocriptine and cabergoline, and both of these are going to be dopamine agonists. These drugs stimulate dopamine receptors to inhibit the release of growth hormone and prolactin. Side effects of this includes orthostatic hypotension, headaches, nausea, abdominal cramps, and constipation. For your patient teaching, your patient needs to seek medical attention for any kind of chest pain, dizziness, or watery nasal discharge. Your patients are going to take bromocriptine with a meal or a snack. We are going to slowly increase the dose, and we want to immediately notify the healthcare provider if pregnancy occurs. For drugs for acromegaly, we are going to look at octreotide and lanreotide. These are going to be somatostatin analogs. And we also have pegvisomant, and this is going to be a growth hormone receptor blocker. In addition to drug therapy, we have radiation therapy, but the results may take months to years, which is why it's the third-line therapy after medication and surgery. For surgical management, we can do what is called a hypophyseectomy, and this is the surgical removal of the pituitary gland and a tumor if it is present. This is the most common treatment of hyperpituitarism. So remember, your pituitary gland, once again, is in your brain. So this procedure is performed transnasally or transsphenoidally. This is going to be done using a bone or a fat patch to close the hole and prevent CSF fluid leakage. As always with any surgery, we have pre-surgical teaching, we have monitoring during and after surgery. So for us, pre-op, we are going to explain that nasal packing will be in place for the first 2 to 3 days, and we want the patient to breathe through the mouth. They will have a mustache dressing, which is just a drip dressing, and it'll be placed under their nose. You want to instruct the patient not to cough, sneeze, blow their nose, or bend forward because this is going to avoid increased intracranial pressure. For post-op care, we are going to do neurochecks hourly. We will document any changes in vision, mental status, level of conscious, or decreased extremity strength. Remember, we are messing around in the head. We want to make sure we're not having any neurological changes. We want to watch for complications, including cerebrospinal fluid leakage, infection, which can be indicated by a headache, fever, or nuchal rigidity. And we want to look for any kind of signs of increased intracranial pressure. Patient teaching. We are going to teach that patient to avoid activities that increase intracranial pressure. We want them to report a post-nasal drip or increased swallowing. We want them to take their hormone therapy as prescribed. We want to prevent constipation to avoid straining because remember, increased straining equals increased intracranial pressure. They are going to also have to avoid brushing their teeth for 2 weeks or until they are cleared. A decreased sense of smell is normal for the first 3 or 4 months. Going back to the cerebrospinal fluid, I do want to let you know, because I don't think I've mentioned it before, if your patient is having drainage from their nose, you can take just a white tissue and wipe their nose, and if you look at that discharge and you notice a halo ring around the discharge coming out, that usually means it's cerebrospinal fluid and you need to let the doctor know. In addition, you guys can look at box 54.3 for nursing care after a hypophyseectomy. Moving on to diabetes insipidus. This is also known as DI. DI stands for dry inside because your patient is going to be urinating out all of their fluid. So this is going to be a disorder of the posterior pituitary where there is water loss occurring, and it's caused by a deficiency of vasopressin or ADH. Remember that ADH is your antidiuretic hormone, and that antidiuretic hormone, I like to call it your no pee-pee hormone. Because what it does is it tells your kidneys, hey, don't excrete all of the fluid that you're getting. I have to reabsorb some of that so we don't get dehydrated. So whenever you don't have enough ADH, then your kidneys are going to be excreting all of the fluid it gets. So it can be caused by a deficiency of vasopressin or ADH, or diabetes insipidus can be caused by the inability of the kidneys to respond to vasopressin. If there's no ADH to tell the body to absorb the water, it means that it is going to be excreted in the urine, and we are going to have dilute urine because we're just having so much of it. So we do have terminology to differentiate between the two types of diabetes insipidus. We have AVPD, which is due to endocrine issues, and AVPR, which is due to kidney issues. We're going to focus on AVPD because that is regarding our endocrine issues, and that's what we are looking at in this unit. For our assessment for patients with diabetes insipidus, remember they are peeing out all this fluid because they don't have anything telling their body to reabsorb the fluid. So the assessment is going to show polyuria, which means frequent urination, nocturia, which is nighttime urination, polydipsia, think about why they are going to have increased thirst because they are peeing out all of their fluids, so they're going to be dehydrated. They're at risk for hypernatremia because they don't have any fluid in their body to help dilute the salt. They are going to have greater than 3 liters of urine output in 24 hours. And their urine-specific gravity is going to be less than 1.005. Make sure these patients do not go longer than 4 hours without fluids because they can become dangerously dehydrated. Moving on to treatment. So desmopressin is going to be used to treat AVPD by replacing natural vasopressin in the body. Now on the opposite side of that, drug therapy can cause water retention, which can cause fluid overload. So teach the patients to weigh themselves daily to identify any weight gain. Immediately call 911 or go to the ER if they experience any signs of water toxicity. This includes a weight gain of 1 kilogram and a headache, acute confusion, or any nausea or vomiting. We also want to work on preventing and managing dehydration. Measure intake and output, check urine-specific gravity, record daily weights, encourage fluid to equal the amount of urine output. Treatment is effective when sodium is lowered, urine-specific gravity increases, and there is an increase in or maintaining of the blood pressure. All right, so we had diabetes insipidus. That was whenever we did not have enough ADH. This is going to be syndrome of inappropriate antidiuretic hormone. This is going to be whenever we have too much ADH. So if we have too much of a hormone that's saying, hey, don't go pee, then your body is going to reabsorb that fluid. So ADH is going to be secreted even when it's not needed, and it's going to cause water retention and fluid overload. This SI is going to be soaked inside, SIADH. So you are going to have fluid overload, you're going to be really wet on the inside. Hyponatremia is going to happen due to all of the excess fluid being held onto. The causes of this are listed in box 54.4, and you really need to understand what kind of patient history could cause SIADH. For our signs and symptoms, early signs are related to water retention, such as GI disturbances, including loss of appetite, nausea, or vomiting. They can also have recent weight gain, hyponatremia, and can cause nervous system problems, especially when it drops below 115. That's that sodium. Whenever your sodium drops below 115, you can experience lethargy, headaches, hostility, disorientations, change in level of consciousness. You can also experience seizures and even a coma. Decreased urine output and elevated urine sodium and specific gravity also occur. For your vital signs, you're going to see a full and bounding pulse due to increased fluid volume, and you can also see hypothermia, that's low temperature, from your central nervous system being disturbed due to your salt fluctuating. Let's move on to the treatment of SIADH. So remember, SI is soaked inside, so treatment is going to focus on restricting fluid, promoting excretion of water, sodium replacement, and preventing the action, the oversecretion, the overuse of ADH. For our drug therapy, vasopressin receptor antagonists such as conivaptan or tolvaptan can promote water excretion without sodium loss. Diuretics may be used when sodium levels are close to normal and the patient has heart failure. Hypertonic saline, that's at 3% sodium chloride, is going to be given when sodium levels are very low. Careful monitoring is going to be needed because it can worsen fluid overload if you're giving someone fluids, and that can promote heart failure. So this is really a dire situation. You're monitoring your patient. There is a drug alert on page 1310. Tolvaptan and conivaptan can cause rapid onset of hypernatremia. Anytime you're playing with someone's fluid and electrolytes, these are things that you need to be thinking of. For your nursing interventions, we're going to monitor for fluid overload. So think about what we're going to be looking for. That could include a bounding pulse, that neck vein distension, lung crackles, dyspnea, peripheral edema, and reduced urine output. This urine is going to be very concentrated. We are going to provide a safe environment. So low sodium can lead to seizures, so we want to reduce environment noise and stimuli. We are going to look at fluid restrictions because fluids further dilute sodium. Use saline to dilute any tube feeds and irrigate GI tubes and give PEG tube medications. We are going to increase the sodium in the diet, and we are going to do frequent assessments. So these are going to be like our neuro checks. We're going to do these often to assess for any kind of central nervous system involvement. So we talked about our pituitary glands. Let's move on to the adrenal gland. So first we're going to talk about adrenal gland hypofunction. So this is when the adrenal cortex production of the steroid hormone aldosterone is decreased. And this is going to happen due to inadequate secretion of adrenocorticotropic hormone, that's ACTH. This can occur when we have problems with the hypothalamic pituitary control mechanisms and problems with the adrenal gland tissue. A lot of time we refer to adrenal gland hypofunction by its primary form, which is Addison's disease. So during this case, we are going to have insufficient steroid hormones, and it's going to lead to problems due to the loss of aldosterone and cortisol. Now, whenever we have decreased cortisol, we can see hypoglycemia, a decrease in gastric acid production and glomerular filtration. We can see excessive BUN, and we can see anorexia and weight loss. Whenever we have decreased aldosterone, we can see disturbances in fluid and electrolytes. Potassium excretion is going to be decreased, and that's going to lead to hyperkalemia. Sodium and water excretion is going to be increased, and that can cause hyponatremia and hypovolemia. Any potassium retention can promote the reabsorption of hydrogen ions, and that can also lead to acidosis. So we have acute adrenocortical insufficiency. This is life-threatening. This occurs when the need for cortisol and aldosterone is greater than what is available. It often occurs in response to stress from surgery, trauma, or severe infection. In this case, sodium levels will fall, potassium levels will rise rapidly, and severe hypotension is caused by the reduced blood volume loss from aldosterone. So let's talk about the primary versus secondary type of adrenal gland hypofunction. So our primary disease is going to be known as Addison's disease. This is often what we discuss. And this is when glucocorticoids, mineralocorticoids, and androgens are reduced. In secondary adrenal gland hypofunction, mineralocorticoids are often not affected. The common cause is the sudden cessation of long-term glucocorticoid drugs, such as hydrocortisone, prednisone, or dexamethasone. Interventions. Box 54.6 is going to detail the key features of adrenal insufficiency. We're really going to be looking at lethargy, fatigue, muscle weakness, hyperpigmentation, vitiligo, hypotension, and body hair loss. Ask about salt intake because adrenal hypofunction can cause salt cravings. Think about why that is. If you're hyponatremic, your body is craving what it needs, so you might be craving salt. Our signs and symptoms include anorexia, nausea, vomiting, diarrhea with abdominal pain, menstrual changes, impotence, hypoglycemia, which is sweating, headaches, tachycardia, and tremors. A lot of times we'll see this hypoglycemia with cortisol deficiencies. We can have hyperkalemia. Hyperkalemia can cause dysrhythmias with the heart rhythm. We may also see hyponatremia, which can cause hypotension and decreased cognition. Salt and sodium are really fond of your brain. They control a lot of your neurologic functions. So anytime you see abnormalities in your sodium electrolyte, you can see neuro changes. Table 52 or 54.2 is going to give you the details of the lab testing. A CT and MRI can help determine the cause of pituitary problems and show adrenal atrophy, but not necessarily its cause. For treatment, we are going to focus on promoting fluid balance, monitoring for fluid deficit, and preventing hypoglycemia. Assessing cardiac function is the priority because hyperkalemia, that's high potassium, can cause dysrhythmias resulting in cardiac arrest. Cortisol and aldosterone deficiencies are corrected with replacement. Prednisone is the most common hormone replacement therapy. Now, prednisone follows a strict dosing schedule to mimic natural hormone cycles. It is best to take prednisone in the morning since this is when levels are usually the highest. Do not restrict salt or start diuretics if it may lead to an adrenal crisis. This is usually called acute adrenal insufficiency or an Addison's crisis. Nursing actions for these include for your acute patients include daily weights, IV corticosteroids, encouraging fluids, high carbohydrate and high protein diets. Box 54.7 is going to detail the emergency management if you have acute episodes or an Addison crisis. So we just talked about the deficiency of hormones from your adrenal gland and how those cause Addison disease. Let's look at the flip side whenever your adrenal glands are producing too much. We are going to look at Cushing's syndrome. This is hypercortisolism. So high levels of cortisol or other glucocorticoids are known as Cushing's syndrome. It is Cushing disease if it is caused by pituitary issues. This can be caused by prolonged steroid use or tumors that cause hypersecretion of cortisol. There is a slow turnover of plasma fatty acids that lead to fat buildup, and we can see truncal obesity, moon face, and a buffalo hump, which is that fat pad between the shoulder blades. There is an increase in tissue protein breakdown, and that is going to lead to decreased muscle mass and strength. It can also lead to thin skin, fragile capillaries, and bone density loss. Patients have a reduced immunity because cortisol shrinks organs containing lymphocytes, such as your spleen and your lymph nodes, and decreases their production. Other symptoms are related to increased androgen, which is testosterone production, and that can cause acne, hirsutism, and oligomenorrhea, which is scant or infrequent periods. Hypercortisolism also causes emotional instability. Patients report not feeling like themselves. Inquire about mood swings, irritability, new confusion or depression, crying or laughing inappropriately, and assure them that this is a part of the disease process and will resolve with drug therapy. 54.10 on page 1315. And the image on the slide here is going to show the different symptoms between Addison, remember that is hypofunction in your adrenal glands, and Cushing's syndrome, remember that is hyperfunction of those hormones in your adrenal gland. I feel like this visual really helps you understand the difference, so please do take the time to look at it. For treatment, we are really going to look at preventing fluid overload and monitoring for signs and symptoms of overload. As we have discussed on previous slides, these signs and symptoms can include a bounding pulse, increased neck vein distension, lung crackles, increasing peripheral edema, and reduced urine output. For drug therapy, we are going to look at drugs that interfere with the production of ACTH or adrenal hormone synthesis. An example would be ketoconazole. For nutrition, we want to have no added salts, and we want to restrict fluids. We are going to monitor intake and output in daily weights. Rapid weight gain is the best indicator of fluid retention, and the best way to look at that is once again getting those daily weights. For surgery, we do have surgical management depending on the cause. Sometimes we have to do the removal of the pituitary tumor. Remember, that can be done through a hypophysectomy if the cause is by the increased secretion of ACTH. Hypercortisolism is caused by an adrenal tumor, or if it is caused by an adrenal tumor, an adrenalectomy can be performed. And that's just what it sounds like. You go through, you can remove the tumor or the whole adrenal gland. We want to prevent injury. These patients are at risk for skin breakdown, fractures, and GI bleeding. For our nursing interventions, we want to make sure we are performing frequent assessments and every 2-hour turns. We want our patient to use a soft toothbrush, an electric shaver, and we want to use a lift sheet to reposition the patient and protect that skin integrity. Use a gait belt when you are walking the patient. Encourage a high-calorie diet with more calcium and vitamin D. We want to reduce or withhold any alcohol. We also want to reduce caffeine and NSAID consumption to lower the risk of GI bleeding. To prevent infection, glucocorticoids are going to reduce inflammation and immune response, making the patient susceptible. So we want to encourage thorough hand washing. We are going to monitor labs, urine, and vitals, and we are going to encourage the patient to avoid large crowds. So our last disorder for this chapter is going to be hyperaldosteronism. This is going to be when we have an increased secretion of aldosterone with mineral low corticoid excess. We have primary hyperaldosteronism, aka Conn syndrome, and it's caused by an excessive secretion of aldosterone from one or both adrenal glands. This is usually due to an adrenal adenoma. We also have secondary hyperaldosteronism, which is the excessive aldosterone from high levels of angiotensin II due to high renin levels. This can be caused by kidney hypoxia, diabetic neuropathy, and the excess use of some diuretics. Signs and symptoms of hyperaldosteronism include hypernatremia, hypokalemia, metabolic acidosis, increased blood volume, and therefore an increased blood pressure. Hypokalemia and hypertension are the most common problems, and here we're going to see a headache, fatigue, muscle weakness, or dehydration. For our diagnostics, we can look at the labs. Our potassium will be low, the sodium will be high. Renin levels are going to be low with an elevated blood pH, and your urine is going to have a low specific gravity, and obviously it's hyperaldosteronism, you're going to have high aldosterone levels. For treatment, surgical removal of one or both of the adrenal glands can happen. Removal of one adrenal gland the patient will have a temporary glucocorticoid replacement, while patients with removal of both will have lifelong replacement because you have two adrenal glands. If you remove one, you'll temporarily be on replacement because the other one will pick up the slack. But if you lose both adrenal glands, you're going to be on lifelong replacement therapy. If surgery is not an option, spironolactone, that is aldactone, is diuretic. It can be used to control hypokalemia and hypotension. Alright, so you guys have been with me for almost 30 minutes, and I know that is a lot of brain power. So if you need to, go take a break, go touch some grass, get some fresh air, pet your dog, do whatever it is you do. Take you a quick break so you have that brain power, and whenever you're ready, come on back, and we will start Chapter 55. Chapter 55 is going to be concepts of care for patients with problems of the thyroid and parathyroid glands. So here we are going to talk about hyper and hypothyroidism and hypo and hyperparathyroidism. Let's start off with hypothyroidism. This is when we have reduced or no hormone secretion in the thyroid gland, and it's going to cause a decreased metabolism. I like to think of hypothyroidism, since it's decreasing our metabolism, it kind of puts you in a light hibernation state. So you have low metabolism, you may be cold, you just don't have that production, that energy that you're supposed to. Your thyroid cells are going to be damaged, or the patient is just not ingesting enough iodine or tyrosine, and this is required to make thyroid hormones. So if you're not getting enough, you're not going to make your thyroid hormones. Low or no thyroid hormones can cause a decreased metabolism. This is going to cause the hypothalamus and anterior pituitary to make TSH, that is your thyroid stimulating hormone. They're going to make TSH to trigger the release of thyroid hormones. So if your thyroid is not producing enough, we are going to have a production of TSH because we want to stimulate your thyroid to make its hormones like it's supposed to. The TSH will then bind to the thyroid and it's going to make it enlarged. This is when you will see that goiter. Measuring TSH will determine if the thyroid is underactive, normal, or overactive. Early stages are easily missed because symptoms can be vague. Buildup of metabolites in the cells can cause an increase in mucus and water-forming cellular edema. This is called myxedema. Myxedema can change a patient's appearance, and it can include the tongue thickening, non-pitting edema, especially on the front of the legs and the top of the feet. A myxedema coma can develop as a rare serious complication of poorly treated or untreated hypothyroidism. For a myxedema coma, this is a decreased metabolism causing the heart muscle to become flabby and the heart chamber sizes to increase. This is going to decrease cardiac output with decreased perfusion and gas exchange for vital organs. This will cause tissue and organ failure in turn. Problems associated with myxedema coma include decreased level of consciousness, respiratory failure, hypotension, hyponatremia, hypothermia, and hypoglycemia, also bradycardia. Box 55.3 has nursing care for a myxedema coma, but mainly I want to point out we're going to maintain airway and aspiration precautions. We are going to check the blood pressure hourly. We are going to do warming measures such as warm blankets. Our patients will be in every 2-hour turn, and we will monitor for any change in mental status. Most cases of hypothyroidism are going to be caused by Hashimoto's thyroiditis. This is an autoimmune problem where the body makes antibodies that attach to the thyroid. This causes inflammation, tissue destruction, and reduced secretion of thyroid hormones. Other causes are radioactive iodine treatment of hyperthyroidism and thyroid surgery. So if you have hyperthyroidism and you get treatment for it, if something goes wrong, it can cause hypothyroidism in return. Hypothyroidism is common in areas where soil and water have little natural iodide. So box 55.2 on page 1326 is going to detail the key features of hypothyroidism. These can include your cardiovascular, respiratory, or GI symptoms, especially those metabolic symptoms. For our assessment, symptoms are related to the slowed metabolism. So lethargy, increased fatigue, generalized weakness, muscle aches, paresthesias, changes in menses, impotence, and infertility can all be symptoms. COVID-19 can aggravate an existing autoimmune thyroid disease and cause us to have hypothyroidism. Bradycardia and bradyapnea and low body temperature, weight gain, goiter, and depression are also symptoms. For our lab findings, we are going to have low T3 and low free and serum T4. So our thyroid levels, once again, are going to be low, and we are going to have high TSH because remember, we are trying to stimulate the thyroid to work, so we're going to have high stimulating hormones. For interventions and treatment, we want to improve gas exchange, so we're going to monitor respiratory status frequently, avoid sedation if possible, because it can make gas exchange worse. For our cardiac output, hypothyroidism can cause increased blood pressure and dysrhythmias. Monitor vitals and heart rhythm frequently. Educate the patient to report any kind of chest pain. Lifelong hormone replacement is required, usually with levothyroxine. This is Synthroid. We are going to start low and go slow with the dosage. For levothyroxine education, once again, this is also known as Synthroid. So it will be a lifelong medication. We are going to take it as prescribed. It needs to be taken on an empty stomach with water. This also needs to be given 30 to 60 minutes before a meal in the morning. A lot of times if you work night shift at the hospital, Synthroid is usually prescribed for 6 a.m. because it is way before breakfast, way before any other meds. We want the patient to take iron, calcium, and antacids for at least 4 hours apart as they can interfere with absorption. It takes 6 weeks to reach its full effect. We want to maintain adequate fiber, fluid, and whole grain intake to prevent any constipation. Levothyroxine can treat bradycardia, that is a result from hypothyroidism as well. So if you have bradycardia because you have hypothyroidism, if you're treating the hypothyroidism, you can treat the bradycardia. So insomnia, tremors, nervousness, diarrhea may mean your dose is too high. You can develop a thyroid crisis characterized by heat intolerance, sweating, tachycardia, insomnia, and hyperthermia. These are basically the symptoms of hyperthyroidism. So if you're taking your Synthroid and your dose is too high, that means your thyroid is working too much and you're going to start exhibiting symptoms of hyperthyroidism. Lethargy and constipation can mean that the dose is too low. We're still having symptoms of hypothyroidism. And you want to immediately report chest pain or dyspnea when you are starting the medication. For preventing a myxedema coma, we are going to take medication as prescribed and notify the healthcare provider of new onset of symptoms. Box 55.3 has the care of the myxedema coma patients, and treatment is started before laboratory confirmation. This is just a little funny slide that I have a couple pictures for you. So this first one is when the Synthroid is due at 7 a.m. Like I said, at Southwell we do it at 6 a.m. to prevent this problem. It doesn't accidentally get given late. So remember, we want that Synthroid to be given before we eat anything, at least 30 to 60 minutes before. You don't really take it with your other medicine, and you drink it with plain old water. And this other picture is just reinforcing that you do have to wait to eat after you take your Synthroid. So we talked about hypothyroidism. Now let's do the complete opposite and talk about hyperthyroidism. So you're going to start seeing a lot of opposite symptoms. So this is when we have excessive thyroid hormone secretion by the thyroid gland. This is going to increase metabolism in all body organs. Symptoms are in box 55.4 and can include tachycardia, increased appetite, increased stools, weight loss, heat intolerance because your metabolism is high. You're already making heat, so that hot environment is not for you. You're going to have amenorrhea, gynecomastia, anxiety or frequent mood changes, restlessness, sweating, wide-eyed, that's exophthalmos. You can also have insomnia or a goiter. You can also have hyperglycemia, fat loss causing weight loss, and nutritional deficits. There are causes of hyperthyroidism. First off, we have Graves' disease. This is an autoimmune disease that causes thyroid-stimulating immunoglobulins to attach to the TSH receptors on thyroid, and is going to trigger and produce thyroid hormones. This causes an increase in cells leading to the enlargement of the thyroid, which will also give you a goiter. Specific Graves' disease symptoms can include exophthalmos, which is those bulging eyes, and pretibial myxedema. We also have toxic multinodular goiters, that's TMNG, and this can be in enlarged thyroid tissue or benign tumors. Those are also known as adenomas. These patients usually have had a goiter for years and milder symptoms than Graves' disease. These patients do not have exophthalmos and pretibial myxedema. Excessive thyroid replacement hormones can also cause hyperthyroidism. As we talked about in the previous slides, if you have Synthroid and your dose is too high, you could start showing symptoms of hyperthyroidism. For our labs, you're going to have that increased T3 and T4. You're going to have those increased thyroid hormones because your thyroid is in overdrive. You are going to have THS. My bad. You can also have TSH, that's your thyroid stimulating hormone. It may be high if you have secondary or tertiary hyperthyroidism, but if you have Graves' disease, your TSH is going to be low because it's trying to get your thyroid to stop making so much T3 and T4. For our diagnostics, we have radioactive iodine uptake, that's RAIU. Radioactive iodine is given by mouth, and the uptake of iodine by the thyroid is going to be measured. RAIU is increased in hyperthyroidism, and it can help identify active thyroid nodules. We can do an ultrasound that's going to determine the size and presence of masses or nodules. We can also do an ECG that would show any kind of SVTs, AFib, or PVCs. In this picture, you can see a goiter, and this is going to be the abnormal enlargement of the thyroid gland. You can also see in this patient, she has a little bit of bulging eyes if you just take a look. For non-surgical management, we are going to monitor vitals often, at least every 4 hours. We are going to report an increase in the temperature of 1 degree Fahrenheit or higher, as this could indicate the onset of a thyroid storm. A thyroid storm is going to be the rapid acceleration of bodily functions, and it is an emergency. It is fatal if it is left untreated. So to prevent a thyroid storm or crisis, we want to reduce stimulus, limit visitors, we give Tylenols for fever, we give a high protein, high calorie diet and encourage fluid intake. We are going to instruct the patient to immediately report symptoms like palpitations, dyspnea, vertigo, or chest pain. We are going to promote comfort, keep the room cool, remember, because these patients, they're not going to do well with heat, they're already running hot. We want to have ice available. We want to change bed linens when damp from sweating, and we give eye drops for patients with exophthalmos. For drug therapy, we have methimazole and iodine. For radioactive iodine therapy, that's RAI therapy, radioactive iodine is taken orally and it is picked up by the thyroid, and some of the cells that make thyroid hormones are destroyed by the radiation. For surgical management, we can have the removal of all or part of the thyroid. A total thyroidectomy is going to be the removal of all of the thyroid, and it requires lifelong hormone replacement. For a subtotal thyroidectomy, this is the removal of part of the thyroid. For post-op care, keep your patient in a semi-Fowler's position with the neck neutral. We are going to monitor for potential complications, such as a parathyroid gland injury. You're working with the thyroid, you have those 4 little parathyroid glands. Did we accidentally nick one or remove one? A parathyroid gland injury can cause hypocalcemia and tetany, so that's tingling around the mouth, fingers, and toes. Assess for muscle twitching. We're also going to check for cramps, hyperactive DTRs, diarrhea, and cardiac dysrhythmias. We want to have calcium gluconate available if needed. For thyroid storm, these are now uncommon due to drug therapy prior to surgery. The signs and symptoms often include a fever and tachycardia. Can also include anxiety, tremors, nausea, vomiting, and diarrhea. As it progresses, the patient can become restless, confused, or psychotic, and they may have seizures. A hemorrhage is likely to occur in the first 24 hours, and there can also be damage to the laryngeal nerves, so that it is going to cause hoarseness and weak voice. Now, with our thyroid gland, remember that is in your throat, and your throat is one of your main airways. So, respiratory distress or reduced gas exchange can occur. So we are going to look at this because it can occur from tetany swelling or laryngeal nerve damage. It can cause spasms or laryngeal stridor, which is a harsh, high-pitched respiration. So whenever we have a thyroidectomy patient who is post-op, we are going to keep a trach kit. That's a tracheostomy kit at the bedside. And we're also going to have oxygen and suction set up. This is so if our patient loses that airway, we have a way to reestablish the airway in an emergency. If stridor is noted upon the assessment, that means we are starting to have some decrease in the integrity of the airway, and we need to go ahead and call a rapid response and be prepared for intubation or that trach placement for the patient. Now that we've discussed our thyroid, let's discuss the parathyroid glands. So these are 4 little glands on the back of your thyroid. They're actually on the posterior side of your neck. So in hypoparathyroidism, the parathyroid is underfunctioning and it is not secreting enough parathyroid hormone, which signals the kidneys to reabsorb calcium and excrete phosphorus. Table 55.3 has the results in hypocalcemia and hyperphosphatemia, and symptoms are related to low calcium, tingling and numbness around the mouth, hands, or feet, to severe muscle cramps, hand or foot spasms, and seizures. Check Chavostics and Trousseau signs, and these positive responses could indicate tetany. This is most often caused by surgery. So remember we talked about you can have surgery on your thyroid. If you nick one of those parathyroids or you accidentally take the whole thing out, you are going to start seeing signs of hypocalcemia. So the treatment is going to be to correct hypocalcemia and prevent kidney stones. We can give IV calcium gluconate, oral vitamin D, and we keep calcium in the low normal range, high enough to prevent hypocalcemia symptoms and low enough to prevent kidney stones. On the flip side of that hypoparathyroidism, we have hyperparathyroidism. This is where parathyroid hormone secretion is increased, causing hypercalcemia and hypophosphatemia. Remember that calcium and phosphate have what kind of relationship? An inverse, and I know you said it because you guys are smart. So excessive parathyroid hormone causes bone to increase osteoclastic activity. So this is the breaking down of the bone. And this is going to release calcium and phosphorus into the blood and decrease bone density. So think your patients are going to be at high risk for fractures here. The signs and symptoms include fractures, weight loss, arthritis, kidney stones, osteoporosis, anorexia, nausea, vomiting, epigastric pain, constipation, and lethargy. For our patient education, we are going to educate the patient that they are at risk for fractures and should try to prevent injury and encourage those low weight-bearing exercises like walking. Also, because your patient's bones can be kind of fragile, we want to make sure that we are using a draw sheet to lift your patient in bed. So that is the end of chapter 54 and 55. I do want to say once again, I understand the endocrine system can be very intimidating. It's a lot of hypo and hypers and fancy names. If there is a concept that you are just not sure about or you don't understand, please reach out to your instructor. We are here to help you. We want to help you. We are the experts on the matter. So if you have any questions at all, please shoot us an email. We'd never mind. I hope you guys enjoyed your lecture and you guys are going to do awesome on your test.